Trauma and Recovery, Part 2, Stages of Recovery, Chapter 7, A Healing Relationship. The core experiences of psychological trauma are disempowerment and disconnection from others. Recovery, therefore, is based upon the empowerment of the survivor and the creation of new connections. Recovery can take place only within the context of relationships. It cannot occur in isolation. In her renewed connections with other people, the survivor recreates the psychological faculties that were damaged or deformed by the traumatic experience. These faculties include the basic capacities for trust, autonomy, initiative, competence, identity, and intimacy. Just as these capabilities are originally formed in relationships with other people, they must be reformed in such relationships. The first principle of recovery is the empowerment of the survivor. She must be the author and arbiter of her own recovery. Others may offer advice, support, assistance, affection, and care, but not cure. Many benevolent and well-intentioned attempts to assist the survivor founder because this fundamental principle of empowerment is not observed. No intervention that takes power away from the survivor can possibly foster her recovery, no matter how much it appears to be in her immediate best interest. In the words of an incest survivor, quote, "Good therapists were those who really validated my experience and helped me to control my behavior rather than trying to control me," end quote. Caregivers schooled in a medical model of treatment often have difficulty grasping this fundamental principle and putting it into practice. In exceptional circumstances where the survivor has totally abdicated responsibility for her own self-care or threatens immediate harm to herself or to others, rapid intervention is required with or without her consent. But even then, there is no need for unilateral action. The survivor should still be consulted about her wishes and offered as much choice as is compatible with the preservation of safety. This principle of restoring control to the traumatized person has been widely recognized. Abram Gardiner defines the role of the therapist as that of an assistant to the patient whose goal is to, quote, "help the patient complete the job that he is trying to do spontaneously," end quote, and to reinstate, quote, "the element of renewed control," end quote. Martin Simons, working with hostages, describes the principles of treatment as restoring power to victims, reducing isolation, diminishing helplessness by increasing the victim's range of choice, and countering the dynamics of dominance in the approach to the victim. The community activists Evan Stark and Anne Flitcraft state as their therapeutic goal with battered women the restoration of autonomy and empowerment. They define autonomy as, quote, "a sense of separateness, flexibility, and self-possession sufficient to define one's self-interest and make significant choices," end quote. While empowerment is, quote, "the convergence of mutual support with individual autonomy," end quote. From their perspective, the same woman who looks like a helpless and deteriorated patient in the traditional medical or mental health clinic may look and act like a strong survivor, quote unquote, in a shelter environment where her experience is validated and her strengths are recognized and encouraged. The relationship between survivor and therapist is one relationship among many. It is by no means the only or even the best relationship in which recovery is fostered. Traumatized people are often reluctant to ask for help of any kind, let alone psychotherapy. But many people who suffer from post-traumatic stress disorder do eventually seek help from the mental health system. For example, a national study of Vietnam veterans found that most combat veterans with a post-traumatic syndrome sought treatment for mental health problems at least once after their return from the war. The therapy relationship is unique in several respects. First, its sole purpose is to promote the recovery of the patient. In the furtherance of this goal, the therapist becomes the patient's ally, placing all the resources of her knowledge, skill, and experience at the patient's disposal. Second, the therapy relationship is unique because of the contract between patient and therapist regarding the use of power. The patient enters therapy in need of help and care. By virtue of this fact, She voluntarily submits herself to an unequal relationship in which the therapist has superior status and power. Feelings related to the universal childhood experience of dependence on a patient are inevitably aroused. These feelings, known as transference, further exaggerate the power imbalance in the therapeutic relationship and render all patients vulnerable to exploitation. It is the therapist's responsibility to use the power that has been conferred upon her only to foster the recovery of the patient, resisting all temptations to abuse. This promise, which is central to the integrity of any therapeutic relationship, is of special importance to patients who are already suffering as the result of another's arbitrary and exploitative exercise of power. In entering the treatment relationship, the therapist promises to respect the patient's autonomy by remaining disinterested and neutral. Disinterested means that the therapist abstains from using her power over the patient to gratify her personal needs. Neutral means that the therapist does not take sides in the patient's inner conflicts or try to direct the patient's life decisions. Constantly reminding herself that the patient is in charge of her own life, the therapist refrains from advancing a personal agenda. This disinterested and neutral stance is an ideal to be striven for, never perfectly attained. The technical neutrality of the therapist is not the same as moral neutrality. Working with victimized people requires a committed moral stance. The therapist is called upon to bear witness to a crime. She must affirm a position of solidarity with the victim. This does not mean a simplistic notion that the victim can do no wrong. Rather, it involves an understanding of the fundamental injustice of the traumatic experience and the need for a resolution that restores some sense of justice. This affirmation expresses itself in the therapist's daily practice, in her language, and above all, in her moral commitment to truth-telling without evasion or disguise. Yael Danieli, a psychologist who works with survivors of the Nazi Holocaust, assumes this moral stance even in the routine process of taking a family history. When survivors speak of their relatives who died, quote-unquote, she affirms that they were rather, quote-unquote, murdered. Quote, therapists and researchers who work with members of survivors' families encounter individuals whom the Holocaust deprived of the normal cycle of the generations and ages. The Holocaust also robbed them, and still does, of natural individual death, and thus of normal mourning. The use of the word death to describe the fate of the survivors' relatives, friends, and communities appears to be a defense against acknowledging murder as possibly the most crucial reality of the Holocaust, end quote. The therapist's role is both intellectual and relational, fostering both insight and empathic connection. Gardiner notes that, quote, the central part of the therapy should always be to enlighten the patient, end quote, as to the nature and meaning of his symptoms, but at the same time, quote, the attitude of the physician in treating these cases is that of the protecting parent. He must help the patient reclaim his grip on the outer world, which can never be done by a perfunctory pill-dispensing attitude, end quote. The psychoanalyst Otto Kernberg makes similar observations on the treatment of patients with borderline personality disorder. Quote, the therapist's empathic attitude, derived from his emotional understanding of himself and from his transitory identification with and concern for the patient, has elements in common with the empathy of the good-enough mother, quote-unquote, with her infant. There is, however, also a totally rational, cognitive, almost ascetic aspect to the therapist's work with the patient, which gives their relation a completely different quality, end quote. The alliance of therapy cannot be taken for granted. It must be painstakingly built by the effort of both patient and therapist. Therapy requires a collaborative working relationship in which both partners act on the basis of their implicit confidence in the value and efficacy of persuasion rather than coercion, ideas rather than force, mutuality rather than authoritarian control. These are precisely the beliefs that have been shattered by the traumatic experience. Trauma damages the patient's ability to enter into a trusting relationship. It also has an indirect but powerful impact on the therapist. As a result, both patient and therapist will have predictable difficulties coming to a working alliance. These difficulties must be understood and anticipated from the outset. Traumatic transference. Patients who suffer from a traumatic syndrome form a characteristic type of transference in the therapy relationship. Their emotional responses to any person in a position of authority have been deformed by the experience of terror. For this reason, traumatic transference reactions have an intense life-or-death quality unparalleled in ordinary therapeutic experience. In Kernberg's words, quote, "It is as if the patient's life depends on keeping the therapist under control," end quote. Some of the most astute observations on the vicissitudes of traumatic transference appear in the classic accounts of the treatment of borderline personality disorder, written when the traumatic origin of the disorder was not yet known. In these accounts, a destructive force appears to intrude repeatedly into the relationship between therapist and patient. This force, which was traditionally attributed to the patient's innate aggression, can now be recognized as the violence of the perpetrator. The psychiatrist Eric Lister remarks that the transference in traumatized patients does not reflect a simple dyadic relationship, but rather a triad. Quote, "The terror is as though the patient and therapist convene in the presence of yet another person. The third image is the victimizer who demanded silence and whose command is now being broken," end quote. The traumatic transference reflects not only the experience of terror, but also the experience of helplessness. At the moment of trauma, the victim is utterly helpless. Unable to defend herself, she cries for help, but no one comes to her aid. She feels totally abandoned. The memory of this experience pervades all subsequent relationships. The greater the patient's emotional conviction of helplessness and abandonment, the more desperately she feels the need for an omnipotent rescuer. Often she casts the therapist in this role. She may develop intensely idealized expectations of the therapist. The idealization of the therapist protects the patient in fantasy against reliving the terror of the trauma. In one successful case, both patient and therapist came to understand the terror at the source of the patient's demand for rescue. Quote, "The therapist remarks, 'It's frightening to need someone so much and not be able to control them.' The patient was moved and continued this thought. 'It's frightening because you can kill me with what you say, or by not caring, or by leaving.' The therapist then added, 'We can see why you need me to be perfect,' end quote. When the therapist fails to live up to these idealized expectations, as she inevitably will fail, the patient is often overcome with fury. Because the patient feels as though her life depends upon her rescuer, she cannot afford to be tolerant. There is no room for human error. The traumatized person's helpless, desperate rage at a rescuer who lapses even momentarily from her role is illustrated in the case of the Vietnam veteran Tim O'Brien, who describes how he felt after being wounded in battle. The need for revenge kept eating at me. At night I sometimes drank too much. I remember getting shot and yelling out for a medic, and then waiting and waiting and waiting, passing out once, then waking up and screaming some more, and how the screaming seemed to make new pain. The awful stink of myself, the sweat and fear. Bobby Jorgensen's clumsy fingers when he finally got around to working on me. I kept going over it all, every detail. I wanted to yell, "You jerk, it's shock, I'm dying." But all I could do was whinny and squeal. I remember that in the hospital and the nurses, I even remembered the rage, but I couldn't feel it anymore. In the end, all I felt was that coldness down inside my chest. Number one, the guy had almost killed me. Number two, there had to be consequences. End quote. This testimony reveals not only the helpless rage of the victim in terror of death, but also the displacement of his rage from perpetrator to caregiver. He feels that the medic, not the enemy, almost killed him. Further compounding his fury is his sense of humiliation and shame. Though he desperately needs the rescuer's help, he is mortified to be seen in his defiled physical condition. As his wounds heal in the hospital, he broods on a plan of revenge, not against the enemy, but against the inept rescuer. Many traumatized people feel similar rage at the caregivers who try to help them and harbor similar fantasies of revenge. In these fantasies, they wish to reduce the disappointing, envied therapist to the same unbearable condition of terror, helplessness, and shame that they themselves have suffered. Though the traumatized patient feels a desperate need to rely on the integrity and competence of the therapist, she cannot do so, for her capacity to trust has been damaged by the traumatic experience. Whereas in other therapeutic relationships, some degree of trust may be presumed from the outset, this presumption is never warranted in the treatment of traumatized patients. The patient enters the therapeutic relationship prey to every sort of doubt and suspicion. She generally assumes that the therapist is either unable or unwilling to help. Until proven otherwise, she assumes that the therapist cannot bear to hear the true story of the trauma. Combat veterans will not form a trusting relationship until they are convinced that the therapist can stand to hear the details of the war story. Rape survivors, hostages, political prisoners, battered women, and Holocaust survivors feel a similar mistrust of the therapist's ability to listen. In the words of one incest survivor, quote, "These therapists sound like they have all the answers, but they back away from the real shitty stuff," end quote. At the same time, however, the patient mistrusts the motives of any therapist who does not back away. She may attribute to the therapist many of the same motives as the perpetrator. She often suspects the therapist of exploitative or voyeuristic intentions. Where the trauma has been repeated and prolonged, the patient's expectations of perverse or malevolent intent can prove especially resistant to change. Patients who have been subjected to chronic trauma and therefore suffer from a complex post-traumatic syndrome also have complex transference reactions. The protracted involvement with the perpetrator has altered the patient's relational style so that she not only fears repeated victimization, but also seems unable to protect herself from it or even appears to invite it. The dynamics of dominance and submission are reenacted in all subsequent relationships, including the therapy. Chronically traumatized patients have an exquisite attunement to unconscious and nonverbal communication. Accustomed over a long time to reading their captors' emotional and cognitive states, survivors bring this ability into the therapy relationship. Kernberg notes the borderline patient's uncanny ability to read the therapist and respond to the therapist's vulnerability. Emmanuel Tenay notes the, quote, sensitivity and intense perceptiveness, end quote, of survivors of the Nazi Holocaust, adding that, quote, fluctuations in attention of the therapist are picked up by these patients with readiness and pathological hypersensitivity, end quote. The patient scrutinizes the therapist's every word and gesture in an attempt to protect herself from the hostile reaction she expects. Because she has no confidence in the therapist's benign intentions, she persistently misinterprets the therapist's motives and reactions. The therapist may eventually react to these hostile attributions in unaccustomed ways. Drawn into the dynamics of dominance and submission, the therapist may inadvertently reenact aspects of the abusive relationship. This dynamic, which has been most extensively studied in borderline patients, has been attributed to the patient's defensive style of projective identification. Once again, the perpetrator plays a shadow role in this type of interaction. When the original trauma is known, the therapist may find an uncanny similarity between the original trauma and its reenactment in therapy. Frank Putnam describes one such instance in a patient with multiple personality disorder. Quote, as a child, the patient had been repeatedly tied up and forced to perform fellatio on her father. During her last hospitalization, she became severely suicidal and anorexic. The staff members tried to feed her through a nasogastric tube, but she kept pulling it out. Consequently, they felt compelled to place her in four-way restraints. The patient was now tied to her bed and having a tube forced down her throat, all in the name of saving her life. Once the similarity of these therapeutic interventions to her earlier abuse was pointed out to all parties, it became possible to discontinue the forced feedings. The reenactment of the relationship with the perpetrator is most evident in the sexualized transference that sometimes emerges in survivors of prolonged childhood sexual abuse. The patient may assume that the only value she can possibly have in the eyes of another, especially in the eyes of a powerful person, is as a sexual object. Here, for example, a therapist describes the final session of a long and successful treatment of an incest survivor who had been diagnosed with borderline personality disorder. Quote, "She now felt like a grown-up daughter. Still, if she did not have intercourse with me, perhaps it was because she was not sexy enough. In the final session, she wondered if I could know how much she appreciated the therapy if she did nothing except thank me verbally. At the door, she realized that perhaps thanking me was sufficient. It was 7 years after our first meeting," end quote. Patients may be quite direct about their desire for a sexual relationship. A few patients may actually demand such a relationship as the only convincing proof of the therapist's caring. At the same time, even these patients dread a reenactment of the sexual relationship in therapy. Such a reenactment simply confirms the patient's belief that all human relationships are corrupt. The patient with multiple personality disorder represents the extreme in the complications of traumatic transference. The transference may be highly fragmented with different components carried by different alters. Putnam suggests that therapists working with these patients prepare for intensely hostile and sexualized transferences as a matter of routine. Even in patients who lack such extreme dissociative capacities, the transference may be disorganized and fragmented, subject to the frequent oscillations that are the hallmark of the traumatic syndromes. The emotional vicissitudes of the recovery relationship are therefore bound to be unpredictable and confusing for patient and therapists alike. Traumatic countertransference. Trauma is contagious. In the role of witness to disaster or atrocity, the therapist at times is emotionally overwhelmed. She experiences to a lesser degree the same terror, rage, and despair as the patient. This phenomenon is known as traumatic countertransference or vicarious traumatization. The therapist may begin to experience symptoms of post-traumatic stress disorder. Hearing the patient's trauma story is bound to revive any personal traumatic experience that the therapist may have suffered in the past. She may also notice imagery associated with the patient's story, intruding into her own waking fantasies or dreams. In one case, the therapist began to have the same grotesque nightmares as her patient, Arthur, a 35-year-old man who had been sadistically abused in childhood by his father. Arthur told his therapist that he still feared his father even though he had been dead for 10 years. He felt that his father was watching him and could control him from beyond the grave. He believed that the only way to overcome his father's demonic power was to unearth his body and drive a stake through his heart. The therapist began to have vivid nightmares of Arthur's father entering her room in the form of a rotting, disinterred body. Engagement in this work thus poses some risks to the therapist's own psychological health. The therapist's adverse reactions, unless understood and contained, also predictably lead to disruptions in the therapeutic alliance with patients and to conflict with professional colleagues. Therapists who work with traumatized people require an ongoing support system to deal with these intense reactions. Just as no survivor can recover alone, no therapist can work with trauma alone. Traumatic countertransference includes the entire range of the therapist's emotional reactions to the survivor and to the traumatic event itself. Among therapists working with survivors of the Nazi Holocaust, Danieli observes an almost impersonal uniformity of emotional responses. She suggests that the Holocaust itself, rather than the individual personalities of therapists or patients, is the primary source of these reactions. This interpretation recognizes the shadow presence of the perpetrator in the relationship between patient and therapist and traces the countertransference, like the transference, to its original source outside of a simple dyadic relationship. In addition to suffering vicarious symptoms of post-traumatic stress disorder, the therapist has to struggle with the same disruptions in relationship as the patient. Repeated exposure to stories of human rapacity and cruelty inevitably challenges the therapist's basic faith. It also heightens her sense of personal vulnerability. She may become more fearful of other people in general and more distrustful even in close relationships. She may find herself becoming increasingly cynical about the motives of others and pessimistic about the human condition. The therapist also empathically shares the patient's experience of helplessness. This may lead the therapist to underestimate the value of her own knowledge and skill, or to lose sight of the patient's strengths and resources. Under the sway of countertransference helplessness, the therapist may also lose confidence in the power of the psychotherapy relationship. It is not uncommon for experienced therapists to feel suddenly incompetent and hopeless in the face of a traumatized patient. Putnam describes experienced therapists as feeling intimidated and quote-unquote de-skilled when they encounter a patient with multiple personality disorder. Similar feelings arise among those who work with survivors of extreme political violence and repression. The case of Irene, a victim of sexual terrorism, illustrates a temporary therapeutic stalemate occasioned by the therapist's loss of confidence. Irene, a 25-year-old woman, came into treatment complaining of a post-traumatic syndrome with prominent hyperarousal intrusive symptoms and severe constriction. Previously sociable, she had withdrawn from most activities and was virtually a prisoner in her home. A year previously, she had fought off a rape attempt on a date. Since that time, the perpetrator had harassed her with obscene, threatening late-night phone calls. He also stalked her and kept her house under surveillance, and she suspected that he had killed her cat. She had gone to the police once, but felt they had no interest in her problems since, quote-unquote, nothing really happened. The therapist identified with Irene's frustration and helplessness. Doubting that psychotherapy had anything to offer, he found himself offering practical advice instead. Irene despondently rejected all of his suggestions, just as she had rejected suggestions from friends, family, and the police. She felt sure that the perpetrator would defeat anything she tried. Therapy was not helping either. Her symptoms worsened, and she began to report thoughts of suicide. Reviewing the case in supervision, the therapist realized that he, like Irene, had been overwhelmed with a feeling of helplessness. Consequently, he had lost confidence in the utility of listening, his basic skill. In the next session, he asked whether Irene had ever told anyone the whole story of what happened to her. Irene said that no one wanted to hear about it. People just wanted her to shape up and get back to normal. The therapist remarked that Irene must feel really alone and wondered if she felt that she could not confide in him either. Irene burst into tears. She had indeed felt that the therapist did not want to listen. In subsequent sessions, as Irene told her story, her symptoms gradually abated. She began to take more action to protect herself, mobilizing her friends and family, and finding more effective ways to get help from the police. Though she reviewed her new strategies with her therapist, she developed them primarily on her own initiative. As a defense against the unbearable feeling of helplessness, the therapist may try to assume the role of a rescuer. The therapist may take on more and more of an advocacy role for the patient. By so doing, she implies that the patient is not capable of acting for herself. The more the therapist accepts the idea that the patient is helpless, the more she perpetrates the traumatic transference and disempowers the patient. Many seasoned and experienced therapists who are ordinarily scrupulously observant of the limits of the therapy relationship find themselves violating the bounds of therapy and assuming the role of a rescuer under the intense pressures of traumatic transference and countertransference. The therapist may feel obliged to extend the limits of therapy sessions or to allow frequent emergency contacts between sessions. She may find herself answering phone calls late at night, on weekends, or even on vacations. Rarely do these extraordinary measures result in improvement. On the contrary, the more helpless, dependent, and incompetent the patient feels, generally the worse her symptoms become. Carried to its logical extreme, the therapist's defense against feelings of helplessness leads to a stance of grandiose specialness or omnipotence. Unless this tendency is analyzed and controlled, the potential for corrupting the therapy relationship is great. All sorts of extreme boundary violations, up to and including sexual intimacy, are frequently rationalized on the basis of the patient's desperate need for rescue and the therapist's extraordinary gifts as a rescuer. Henry Crystal, who works with survivors of the Nazi Holocaust, observes that the therapist's, quote, impulse to play God is as ubiquitous as it is pathogenic, end quote. The psychoanalysts John Maltzberger and Dan Bowie sound a similar warning. Quote, the three most common narcissistic snares are the aspirations to heal all, know all, and love all. Since such gifts are no more accessible to the contemporary psychotherapist than they were to Faust, unless such trends are worked out, the therapist will be subjected to a sense of Faustian helplessness and discouragement and tempted to solve his dilemma by resort to magical and destructive action, end quote. In addition to identifying with the victim's helplessness, the therapist identifies with the victim's rage. The therapist may experience the extremes of anger from inarticulate fury through the intermediate ranges of frustration and irritability to abstract righteous indignation. This anger may be directed not only at the perpetrator, but also at bystanders who failed to intercede, at colleagues who failed to understand, and generally at the larger society. Through empathic identification, the therapist may also become aware of the depths of the patient's rage and may become fearful of the patient. Once again, this counter-transference reaction, if unanalyzed, can lead to actions that disempower the patient. At one extreme, the therapist may preempt the patient's anger with her own, or at the other extreme, she may become too deferential toward the patient's anger. The case of Kelly, a survivor of childhood abuse, illustrates the error of adopting a placating stance toward the patient. Kelly, a 40-year-old woman with a long history of stormy relationships and unsuccessful psychotherapy, began a new therapy relationship with the goal of getting out of my anger. She persuaded her therapist that only unconditional acceptance of her anger could help her to develop trust. In session after session, Kelly berated her therapist, who felt intimidated and unable to set limits. Instead of developing trust, Kelly came to see the therapist as inept and incompetent. She complained that the therapist was just like her mother, who had helplessly tolerated her father's violence in the family. And I'm going to pause that chapter right there.